Thank you so much, Chris. It's good to be here. It's good to be back here to speak a little bit about denials management and specifically more of a process implementation discussion and trying to dig in a little deep to figure out how we can partner together to ensure we all win the race when it comes to denials. And we'll dig in a little bit to talk about some of the things through experience that I have seen payers try with different payer tactics as such. And so first, I'd like to start off with our polling questions that was presented to me. So the first one was, can you please provide some insight on what payers often use for criteria to clinically validate conditions? And I think that's a really great question because it's no different than what we use in our CDI profession. They use the same evidence-based clinical definitions that we use for the most part, at least when it comes to AKI. I've seen them use KDIGO. That's pretty much an industry standard for acute kidney injury, also for malnutrition. I've seen them use Aspen criteria and also the GLIM, and even a mixture of both sometimes. In addition to sepsis, using more sepsis 3 clinical definition than the traditional sepsis 2. And that's where we run into, I think, a challenge because most institutions are still using SEP2 definition. But I think we always need to keep in mind that within, even though you're still using sepsis 2, sepsis 3 really hones in on that organ failure component. And so if you have severe sepsis, try to dig in a little deep of that organ failure component and see if you can get your patient to meet that SEP3 clinical definition when you're focusing in on denials. And also when it comes to malnutrition, Aspen versus GLIM, there are a lot of similarities between these two clinical definitions. And I think you need to be mindful of that and hone in on that as well when it comes to any clinical validation denials that are present. The second polling question was about what are some of the common resources used for research for appeals? And so my go-to clinical definition or clinical reference tool is UpToDate. It's a peer-reviewed platform where you can look up any clinical diagnosis and read about the clinical criteria that's utilized to diagnose. And this is for physicians by physicians. So it's a powerful tool to use for clinical validation denials.
Fantastic. And Shirlivia, just to step back too, right? Just having that flexibility, I think, came out in our previous conversations, right? Being able to use Aspen or GLIM depending on kind of how that denial process is kind of going, right? But still kind of setting it up to allow you to be able to have that flexibility to relate to either one.
That's right, Chris. I think, for example, when we're talking about Aspen versus GLIM, so GLIM uses BMI and Aspen does not. But what criteria that Aspen does use that GLIM does not, that will make you kind of think about a BMI, is actually weight loss. So typically some patients with extreme weight loss could have a BMI that's lower. And so you want to kind of think about what's similar and what criteria you can use to identify what's in GLIM versus what's in Aspen.
Perfect. Thank you.
Thank you, Chris. So our next, I think, area of opportunity that we need to hone in on wherever you are and you're looking at denials is current challenges. So honing in on that and trying to figure out how you can collaborate in a better way and who you need to collaborate with. So some of those things are, if you don't identify your challenges, you can the payer can kind of have the advantage here. So the advantage for follow-up and follow-through, there are timelines associated with every denial. So you want to ensure that you follow up and follow through, because if not, the payer can send a letter for recoupment of payment because you didn't follow up and follow through. So there's no proof that you actually wrote a denial, or I'm sorry, an appeal. So the lack of understanding of your payer mix and contracts. There are contracts out there for most payers. And so look at the terms within those contracts and what your rights are and what you can and cannot do. Patient financial services and keeping them informed is very important, because whenever a payer goes back to actually request the payment, they're going through patient financial services. So a lot of times when we're talking about denials, there are third party entities that are reviewing these cases for the payer. So EquiClaim, OmniClaim, Cotivity, they will review the your charts for a clinical denial for payers. And so they really know, I think there's a lot of tactics out there and how they can take advantage of the situation if we do not identify our current challenges and ensure we are on top of things. Statistics and what's your top denied diagnoses, and also your financial impact, your loss versus your gain. Tracking and trending is a must. And then medical records are not being sent with denials. I think this is very, very important because a payer can say, you sent the appeal, but I didn't get the records. So there are levels of appeals that is involved in this process. So it's important, again, to know your rights and know what you can and cannot do. And I think ultimately the goal is to work through a standardized and collaborative process to successfully win an appeal.
And Shirlivia, with that too, right? The patient financial services that kind of comes into play as far as identifying kind of what other areas do denials impact, and then ultimately, what is their role in that, and how can we get a overall collective approach so you're on your toes rather than on your heels when you're talking about really aligning all of those key stakeholders or individuals that you can pull in to allow for you that flexibility and almost insulation of any claim.
Yeah, I think you want to ensure to bring in all of your key stakeholders for any claim. And I think the flexibility is in the process, right?
Right.
So how do you start? And so I think what we're talking about is recognizing the need, um, setting the stage by identifying your denials. I think there's a multitude of different denials, and I'm speaking a lot about clinical validation. At least that's been my area of expertise. But there are other denials, and so you need to set the stage and identify the types of denials. And then it's very important that you all speak the same language. And so remember, your terminology for certain things may be different than patient financial services.
Right.
And so we always got to think about that. And I think, Chris, we talked about working with patient financial services to understand the revenue associated with each type of denial is your bread and butter. We want to ensure we secure the revenue that we've received. And when we're talking about clinical validation denials, a lot of times those are charts where we've received payment. And so distinguishing the types of denials in which CDI are, if you have a different role, such as an analyst should leverage and establish some type of monthly meetings or some type of ongoing communication so you can continue to cultivate and fine tune the denials process. And I think we've talked about all of these stakeholders here, from coding to CDI, PFS, which is our patient financial services, HIM, ROI, management support, and physician advisor, depending upon different levels of appeals and where you will go with your denials process. So I think, Chris, those are some of the areas that I would really reflect on when we're talking about patient financial services and engaging them as a whole, and the multitude of other stakeholders we should be thinking about when we're working through denials.
Absolutely. Any suggestions or um, any things that you've seen through your experience that allow you to kind of have some common ground with all those key stakeholders, kind of bringing them together around a denials management approach? Anything that everybody kind of has in common that everybody can get behind as it relates to that denials? Like, just any tidbits as far as maybe pulling in maybe some of those other departments that some individuals may have not understood or may have overlooked that they are part of the process, and then just really kind of getting their buy-in. Anything from any of those areas that you would suggest that you can all kind of wrap your arms around, whether that be a specific, diagnosis you're always seeing that everybody kind of has a common understanding of, or just the dialogue that allows you to get on, speak the same language with those other individuals.
So I think, Chris, when it comes to that common ground, it's all about the finances.
Right.
And then how does the money flow back and forth? And what does that mean from a claim viewpoint? So when we're thinking about patient financial services and the amount of money that's associated with the claim, we can look at claims two ways. So we can look at a claim or even a patient's chart two ways when it comes to the finance side. Is it an open versus a closed claim? And so an open claim is a chart where we haven't billed the case, so we haven't received payment on this particular patient encounter yet. And so those claims are still open, they're at the forefront. And so patient financial services are very much aware of an open claim because they're working it, working on processing that claim to ensure payment is received. Where the biggest challenge is on the closed claim. And when we're talking about a clinical denial, a lot of times those are closed claims, meaning we've received payment. And so
Right.
when you've received payment, it's kind of a closed case because the claim is
Right.
closed.
Yeah. It's done, right? Yeah. Absolutely.
It's done. So I think you have to really hone in on that with patient financial services because when a claim is closed, it's not being monitored. So whenever a payer audits you and requests monies back and it goes through patient financial services, it kind of gets lost or hidden because it's if they repay it, it goes back into the big pool of finances. It's not associated with the claim per se, so it's lost. And until that money continues to grow, that you're paying back to your insurance companies, no one knows that this process is actually in existence.
Right.
And as we're
Lost in
and
translation, right?
perfect terminology, lost in translation. And so you have to be able to ensure that you help your patient financial services team to understand the differences and you collaborate on those differences and what that means. And I think that's key in working towards speaking the same language and getting to that level of understanding of how impactful these denials are. Because when it comes to these closed claims, we're talking about a paper denial, so it doesn't hit a remit, and so that's something also that's important to speak to with the patient financial services um, person is that this is not going to populate on the remit. An example, I was having a conversation and you could engage your patient financial services team and you can say, um, we have all these denials and they can tell you, yes, I track them. I know how much denials we have. Are you aware of that? And I will say to them, absolutely. I know you're tracking all your denials. That's on the remit. But what I'm talking about doesn't hit a remit. It's a closed
Right.
claim. It's been paid. Yes.
Shirlivia, would you say any similarities, right? If I'm taking a look at this and I want to pick one versus the other, right? Much like clinics versus ED on the outpatient side, would you say for programs that are looking to really start the process of honing in on a denials management focus, would you say either open versus closed claims as it relates to a denials management process if I wanted to start in one area or the other? Would you weight one over the other as far as maybe process you can control more versus the other? or just may have, a little bit more insight as far as what your impacts are because of your proactive approach. Is it beneficial maybe to start on one side versus the other if, we're talking about those programs that may not be robust but are looking for a small area to start, and maybe one of those differentiators an open versus a closed claim?
So that's a good question because open claims are something that has always been monitored. If something hits a remit, this goes uh, back in time. It's always been to the forefront. So an open
Right.
claim that hits a remit has always been to the forefront. It's something that's tracked, trend, and monitored in organizations today. So whether it's on the inpatient or outpatient side, so that's something that's done. It's kind of said and done. I think
Right.
our challenge is those closed claims for the most part. And so on a closed claim, it's hard to track and trend if you're not aware,
Okay.
because it's not associated with an open claim. So you have to develop a process to track and trend that. So I would say an open claim, organizations have likely perfected that. And on a closed claim, I think there's more opportunity. I also want to bring this point forward as well that you can still have a closed claim and have a written denial sent for a clinical validation.
Oh,
Um,
interesting.
and we see that on, mostly I've seen it on the inpatient side of things. And when I'm talking about clinical validation, that's kind of my area of focus here. So it happens, and that's why you have to be aware of all of this. And so it's important to establish a standard process to have that same single point of entry for all your denials. And
Right.
perhaps it makes sense for that single point of entry to be your patient financial services team, because in an open claim and on the remit, it will always go to patient financial services.
Right. So
Um,
that's already kind
and
of pre-embedded with that, right, as that first entry point, regardless.
yes, so
Got it.
yes. So those are all great things, and I think ultimately it's about how to win the chess game when it comes to payer tactics, because they are so much aware of. I think they seem to be aware of how a closed claim works versus an open claim. These payers,
Right.
or
Right.
at least the entities that are working with them. And so, from my viewpoint, it seems that we are that if we don't hone in on our process, we are definitely feeding into the game or allowing them to win.
Yeah, yeah, no, and hey, that brings up a good point, right? Very much process oriented, right? Is a good line of defense, within any denials management, right? If you have the workflow, if you have the process down, or at least an understanding of kind of the next steps that things need to go through, and everybody's involved, you're just well more in a defense mode to be able to then rely on those stakeholders for wherever part of that flow it kind of comes into play from a denials perspective, I would imagine.
Yes, it does, because some of the tactics that I've seen the um, payers play, or should I say, sometimes the entities that are reviewing these claims for payers, because I mentioned earlier that a lot of these insurance companies will have a third party entity that's reviewing the claims for them. And
Right.
a lot of times the process is very lengthy with no resolution. And so, again, if you're not following up and following through, you don't know where you are in the process. So,
Yeah, absolutely.
I mean, they can play the waiting game, and that's what chess is all about, right? Wait for your
Yeah.
partner to make the
Patience,
right
right?
move.
Absolutely. So, and touching on that point, you were talking about timeline, right? Meaning, the clock is ticking. Any, me being a novice, right? Anything in particular that stands out as far as, any of those timelines to really adhere to, as it relates to, starting that process when you do get a denial to come through? Is that something to jump on immediately, or is that something to where you kind of have a process that aligns with kind of going through the motions internally and then kind of going through your own internal process? Or what are your thoughts on that? I guess what's the expiration as it relates to being able to address a denial?
So that's a great question. When it comes to timelines, the most important piece is that single point of entry, right?
Right.
Because when a denial comes through, and it's a written denial on a closed claim, you typically have 30 days to write your appeal letter, okay?
Okay, perfect.
And so that's your first timeline. When you write your initial appeal letter, a lot of times the third party entity or the payer has 30 days to respond to you. And so there are timelines that you need to adhere to. If for some reason you don't get the initial denial within 30 days, you can call and ask for an extension. But as I'm
Okay.
talking through this process, do you realize how important it is to have your process honed in, standardized, and all of the key stakeholders knows what's going on? Because historically, in some of my previous experience, I've seen payers wait sometimes 6, 9 months, and then they'll send the recoupment letter for the for the
No, that's
denial.
them. That's them waiting out their chess move, right? Knowing exactly where they want to go.
Yes. And so if not everybody knows what's going on, they'll send the recoupment letter prior to the denial process being completed because the process may not be standardized. All key stakeholders may not know what's going on. And then they get the repayment because we think if you receive something, you think it's valid, and in theory it's valid, but because any payer is allowed to audit. That's pretty standard within any contract they have with a hospital.
Right.
However, they have to allow the hospital to go through the appeals process, right, or the denials process and the process to appeal. So I think we talked about the amount of time it's taking. It's a lengthy process overall,
Right.
from
Absolutely.
start to finish, and so that's why it's so important that you have a very standard process and know what everybody is doing. PFS knows what CDI is doing if they're writing the letter, or whoever's writing the letter. Every key stakeholder knows what's going on, and so tracking and trending, I think we talked about a little earlier on, that's a must. And I think knowing your contract, engage your contracting team, because there are some payers where when a patient is in-house and there's the medical necessity appeals in the URUM area, and they'll use that as a level one of appeal. Typically, most appeals have different levels you can go through. And once you've exhausted all those levels and you have not successfully been able to overturn, then ultimately the monies must be given back. So you have to be aware of all of these key things to win the race. These are some high level examples from experience here, where there's different levels of appeals for different payers. And
Right.
so UHC and Medicare Advantage, typically there has been 3 levels of appeals. There's a written, a peer-to-peer, and the third level usually goes back actually to the payer themselves for their medical director to review it. The first 2 levels of appeals is usually with the third-party entity who's reviewing the chart on behalf of UHC, for example, if that's where this process I've seen to be their levels of appeal.
Right.
The level 2 for peer-to-peer, anybody can join, and I've actually participated in peer-to-peer um, levels of denial appeals process, and it's quite interesting. And I think you learn a lot.
Any suggestions as far as do you think there's almost like an escalation process internally, meaning the facility is bringing on, let's say, additional layers within each one of those levels. So meaning if you're starting out with just writing an appeals letter and then you have the peer-to-peer, do you see almost different individuals engaged from the facility level depending on what level it is? So meaning if you move to that level 3 and you're talking about, you know, a UHC medical director, a payer medical director, is that something where you would engage a physician champion or, you know, any other individuals on the facility side? Have you seen any of those um, variations on who is participating on the facility side aid in any of the success rates or, you know, anything along those lines?
Yes, so the peer-to-peer, that's a great question. Peer-to-peer, a physician has to be involved in that process.
Right,
And that is the key person that needs to be involved in that process is a physician. And so historically, you know, in my previous experiences, we've typically engaged our physician advisors to do that. And this is from historical experience. So that's a great question because in the peer-to-peer, a physician has to be a part of that process. But I have experienced them allowing others to join. And so typically in the peer-to-peer calls I participated in from my previous experience is they typically have the physician. Sometimes there's a coder or the person who actually did the initial letter writing of this clinical denial because it's not a physician that gets involved in the forefront. Because
right,
again, these payers are using evidence-based clinical definitions just like we are, but a physician is always involved in that peer-to-peer, and you as well will need a physician in those different levels of appeals, as well as finding out what levels of appeals are available to you with each payer. So and again, engaging with your contract team to understand what the language is in contracts themselves, um, reading those administrative guides for those payers. There is language in there as well. I didn't say you have to do your homework there, but once you hone in on what levels of appeals is available for each specific payer, because they're not all the same,
right.
you are really on your way to success. And
I
I
almost,
think,
yeah,
go
and
ahead.
I almost see that as almost like a debrief and a teaching opportunity, right, within the facility, no matter which way the denial goes, right? I feel like if you bring individuals in on each one of those levels, maybe not necessarily to overall participate, but just be a part of, right? To have an understanding of kind of how that goes, to then use that almost as an educational tool for maybe, you know, those appeal processes that maybe didn't go the facility way, but maybe why, right? Was it a technicality? Was it something that we could have documented better? You know, where was that? Just use that process, albeit I know it's lengthy and challenging, but just to get individuals to understand what that looks like from start to finish, and then be better prepared, you know, moving forward.
hmm And I think, who do you identify as your key stakeholders? This is what you have to think through. And as you're thinking about your levels of appeals, your payer tactics, how can you fine tune your current denials process? Because I think every institution, hospital has a denials process in place. And so it's
Right.
just about how can you fine tune it. And I think that's what we're looking at currently here at UC Davis is how can we fine tune it? Because we have a process, but there's always opportunity to hone and fine tune and ensure that you've engaged all your key stakeholders. And then looking at those top denied diagnosis and what's the evidence-based clinical definitions that you're using within your institutions and also what the payer is using. Again, tracking and trending is a must. We talked about that a little earlier on. And so, Chris, I hope this information has provided some level of value to the participants as they are engaging in their institutions on clinical denials or denials as a whole and thinking through how can they fine tune and then for me the area that I've been very passionate about these last 10 years or so is specifically the clinical validation denials as it relates to either, CDI or coding, who's ever doing those clinical reviews for you or the denials reviews for you. And so I think that's the area of opportunity here. Thank you.
No, absolutely, Shirlivia. And I think you bring up some really good points, right? Um, Understanding involving individuals in the process, right? Understanding subtleties, closed versus open, maybe differences of approaches, right? And then ultimately, like you said, understanding the contracts, right? Understanding what your appeal process is. And I think even just being able to collect all of that information initially, regardless where a denials management program is or is not, right? And just really get an understanding of that, I think can provide a lot of clarity based off of, like you said, tracking and trending, right? You can really get into that nitty gritty, but the only way you can do that is really if you have that refined process, right? And you're always moving with it rather than against it, and allowing those that information that does come out, good, bad, or indifferent, to be applied in a future state in a process that is always ever growing, but not really changing all of that much, right? Just kind of having different variations to it.
Yes, you make a really good point there. I think ultimately it's about continuing to engage your key stakeholders. Once you're at a good place when it comes to your process, it doesn't mean that you shouldn't reevaluate and fine tune always. So I
Right.
think you always want to be mindful of that. And I know that we have two other great panelists here that has a lot of experience and can speak a lot to some of their wins and areas where they fine tuned and hone in on within their organizations as well.